Dr. Amanda with Straightsmile Solutions, straightsmilesolutions.com. I'm going to hesitate to do another video, and this is going to be a little bit more about when a patient asks for upper or lower braces only, or single arch braces only, or single arch Invisalign or clear aligners only. Let's take upper and lower each at a time and talk about some of the one-off situations where it might be okay, but I like to always preface this that I never say okay until I toss it into the Clin Check. And even if you are doing braces, I still want you to toss it into a Clin Check or a ClearCorrect Clear Pilot setup. Why? Because it calculates the Bolton for you. And if it's a class 1 case and you have a Bolton, it's probably a no-go. So, and you know, sometimes your eye just can't detect it. So it just lets you know if it's gonna work out or not. I just feel a little bit more comfortable. Also, second rule, besides number 1, I toss it into either the Clin Check for Invisalign or the Clear Pilot setup for ClearCorrect. And number 2 rule is that I never say okay until, I check the contacts, see if there's any anterior contacts would be another thing. I always double check on that. And also number 3 rule is that I never, ever, ever give a discount on single arch treatment, because that is one reason why patients want to ask for it, is because they think they're going to get a discount. These cases tend to be significantly more difficult. Why? Because instead of working with 2 arches simultaneously to get things to fit together, we're only working with 1. So it's like way harder, and it takes way longer actually. It's not fast for the most part, especially if it involves anything with back teeth. And even if it only involves front teeth, unless there's a couple one-offs where it works, but for the most part, it's often ends up later having to involve back teeth. And very often you might have to switch it to dual arch. So even if you think you can do it, you don't give a discount. And you let them know, they sign something saying that if needed, they will have to switch to dual arch. You know, if you do all that and you get all that written up, you can say we can give it a try. There's no discount. We might have to switch to dual arch. Treatment may take longer. You know, usually they often change their mind and they agree to go with dual arch. But I'll give you a few examples where it might be okay. And I think the part a lot of you have difficulty with is that there might be a case where the patient has really straight bottom teeth and maybe just their number 7 or their number 8 is rotated, but it's maybe like 3 or 4 millimeters rotated. Well, how are you going to get space? Because let's talk about all the different ways to get space, right? You should go into my video. It's entitled Crowding. It has some other title, but I know crowding is a keyword because it's how I search for it. And I go over the 5 different ways you can make space: extractions, IPR, what else? Expansion of the arches, proclination, and sequential distalization. Those are our 5 key ways that we make space. It's the only 5 that I know of to make space. So if you're only doing single arch, that eliminates most of those. We can't do expansion. Why? Because we're only doing 1 arch. If we expand 1 arch without the other, they're not going to be coordinated. So that's out, okay? What else? We can't do extraction for sure. For single arch, that's out. Can't do sequential distalization because that involves back teeth, and that will really mess things up if you only do 1 arch. So that's out. So what do we have left? IPR and proclination. That's it. That's the only 2 ways you can do it. Those 2 options. Okay. So IPR will work, but not if it's that much crowding, because the max IPR I can put in, and again, if I'm doing single arch, I'm only doing front teeth, okay? I'm not moving back teeth, because same reason, if you start moving back teeth, you're gonna lose your arch coordination. So I'm only doing front teeth, say canine to canine, 3 to 3, that's it. The max IPR I can put in, that would be 5 sites, mesial of the canine, you know? And then basically from the mesial canine to the other mesial canine, that's 5 sites. The max you can put in, and this is assuming your patient is old enough to do this, and if they're young, this is gonna be less, is gonna be 0.5 millimeters per site, okay? So it would not be enough to straighten it. And that's if you went to town on the enamel. And who wants to have that much enamel reduced? First of all, the teeth are gonna look bad. I would never do that on front teeth. They're gonna be sensitive. It's just, that's not a smart move. What else? So we talked about IPR. Proclination, sure. If it's possible to bow out just 1 arch, but usually it just looks weird if you do that. It just doesn't quite work out, and a lot of that depends on the contacts. If you just tip everything forward on just 1 arch, usually the contacts are weird. But there might be a situation, so let's say the patient's a little bit class 2, has a little bit of overjet, has a gap between 8 and 9, upper ones. Okay, I can do that, no problem, no problem. That I can do, upper only, no problem. Flip side, patient has a little bit of overjet. Lower, we take a Ceph or a CBCT sagittal slice. Lower incisors are upright. Sure, we're not going to hit the top teeth. I can do lower only, just the front teeth. They bow out, that's fine because they were upright to begin with, so that's not a problem, right? Yeah, that would be my two exceptions of where I feel pretty comfortable doing it is with overjet. Otherwise, with your regular class 1, yeah, probably no. So hopefully that was helpful. Hopefully that give you some foundation so that you can say no to your patients and let them know why it's not a great idea. And set up your restrictions so that you don't get yourself in trouble doing these cases. All right, thanks so much.